So what is United doing to address social determinants of health? We are committed to working to address complex intersection of health and housing. We are taking a variety of strategies in this space, including financing, which we've invested millions of dollars to build 56 affordable housing communities in 14 states. These communities have helped create more than 2,700 affordable homes for individuals and families, including senior citizens, military veterans, people living with disabilities, and also those who are struggling with homelessness. For housing, we've addressed issues of housing and other social determinants within our service model. And so our staff asks questions regarding housing and facilitates linkages to housing resources. And our clinical team leverages data for those social determinants of health for risk adjusting and programming. And we also have lots of pilot programs in place that work in collaboration with supportive housing providers. And so we know that supportive housing has achieved many positive outcomes, such as reductions in ER visits, inpatient stays, ambulance use, detox visits, and it's also increased outpatient use and preventive services. So understanding the rate of homelessness among individuals that we serve and how that links to the utilization has driven our interest and determined where we focused our efforts. And we've got a really great pilot project in Arizona called My Connections, and it focuses on housing. And we found through that data that those experiencing homelessness in that area were also dealing with acute and chronic renal failure, COPD, diabetes, epilepsy, psychotic disorders, mood disorders, substance abuse, really important things that can be detrimental to one's health. We've also recently published a paper with Healthcare for Homeless, exploring opportunities and sharing priorities between MCOs and healthcare for the homeless providers. For United, we've developed core service lines and capabilities that are designed to address social determinants holistically, and our goal is to improve access to and delivery of community resources. We believe that those are the gateway to overall well-being and ultimately to impact health outcomes positively. Some other things that United has in place are personalized supports, which are physical locations of varying formats that serve as a centralized channel for members or consumers to access a wide range of support services. And so these are storefronts where staff are available to assist with resources that members may need in several states. Housing, as I've spoken about, we continue to create affordable housing and support in helping low-income consumers navigate housing options. And also transportation. We provide, in many markets, reliable transportation for non-emergency medical and social service appointments. That includes medical, dental, and behavioral health appointments that members may have. So as you can see, we've got several social determinant of health specific questions that are embedded in assessments that we have at United. We ask about food, utilities, clothing, housing issues. Not only do you have housing, but do you have safe housing? Do you have stable housing? Are there environmental hazards in your home that impact your health or that are of concern to you? So these are just a few examples of questions that we regularly ask members who we are in contact with. And if they do endorse any of these questions, we have a comprehensive social determinants of health assessment that we can complete to further delve into where needs may be and how to remove some of those barriers. So this is my favorite part, what I'm most excited to talk with everyone about. It's a case example of a gentleman living in Texas. I actually run a pilot at United that focuses on members with complex health needs who have really not responded well to traditional case management outreaches. And so this gentleman is part of a pilot that I'm responsible for. So he is 61 years old. When we met him, he was living in an unlicensed personal care home. He has a history of behavioral health issues, medical issues, and also some substance abuse struggles. He was going in and out of the hospital for medical reasons and behavioral health reasons quite a bit. I might add that we got involved with him in late September of 2018. He is currently still on our caseload today. But after each discharge, we found that once aftercare was in place for him, he was not following up with things. He was a bit elusive, and when he would discharge from the hospital, he was pretty hard to outreach via telephone. We found out later that he didn't have a phone. He didn't have a cell phone. He was living in a personal care home that did not have great conditions. You couldn't reach him on the phone. They did have a landline, but it was difficult to get anyone to answer, and a lot of times people would hang up, or just they weren't helpful in even getting our gentleman to the phone. So after we made face-to-face connection with him, we for the pilot, the vast majority of our contact with our members is face-to-face in the environment, in their home, or in their community. And we found very quickly that this was a gentleman who was very proud of his appearance. He liked to dress up. He liked to be clean and clean-shaven. But this gentleman had not had a haircut in months. He had toenails so long that he couldn't even put shoes on. His shoes were falling apart. So if he could put them on, they wouldn't have lasted very long. But we found that the personal care home was not managing his needs. He was receiving a little over $700 a month. The vast majority of that went to pay for residency at this personal care home. It was supposed to include meals, but oftentimes that meal may have consisted of a bologna sandwich. Sometimes there was no food in the house. It was pretty unpredictable as to when he may get to eat or what he may eat. So, and even something as simple as getting his toenails cut, we couldn't get a doctor's office to do it because he didn't have diabetes. We got pretty creative, and there are nail salons on most corners in most cities. And so we finally connected with a nail salon just to get his nails cut so he could put his shoes on. So that was one of the reasons that he wasn't following up for aftercare. He also was not aware that there was transportation available in his city for aftercare appointments for medical and behavioral appointments. So we did help connect him with that so that he could consistently make those outpatient appointments. One other social determinant of health that was a barrier for him was that we found he didn't have a picture ID. And especially for new providers, they want you to come with your insurance card and your picture ID. He didn't have that, and so he was never able to get through the door for appointments. So he was deemed as never showing up for appointments, but he was trying to go to appointments. He just didn't have a picture ID to show, and he didn't have the money to get a new one. They're about $35, and that's a lot of money. It was a lot of money for him, and the majority of his money went to the personal care home. He didn't have it. So we did find a program in the city where he lives through the police department who was able to get him they covered the cost of another picture ID. We got him transportation to the DMV. He was able to get a picture ID and was able to begin going to aftercare appointments, and has not had another medical admission since then, we're proud to say. The next thing that once we started getting him connected to outpatient services, we started assisting him with finding a different place to live. Windows were broken out in that personal care home. He's 61 years old and was sleeping on a mattress on the floor. So we were able to find a licensed personal care home that was a much better fit for him and had more staff in place who could really attend to things that he needed. They also offered transportation as well, so that if the transportation provided through his insurance fell through, he would have a backup. The personal care home where he lives now also consistently picks up medications for him and assists him with making sure that medications are in his pill box and give him reminders to take those. So I'm really proud to say that he has been stable in his community since the barriers of unstable housing, picture identification, and just some of the activities of daily living that were barriers for him as well. Once those were removed, he has been doing just beautifully. Substance abuse was continued to be an issue for him. He drank pretty heavily, but once he got to a new personal care home and he really was better taken care of physically and emotionally, he decided on his own that he wanted to stop drinking. We helped him get admitted to a detox facility. He went straight to a residential treatment facility, a 30-day inpatient facility where he did wonderfully, stepped him down to a partial hospitalization program, and again down to an intensive outpatient program, because he has done so well, and he has remained sober and is now beginning to sponsor others. So social determinants of health were a big part of this gentleman's difficulties, and once we were able to identify those and remove some of those barriers, it really has made a difference for him. So I'm happy to share that he's doing well, and that is it for my part of the presentation, and I think Pam is up next.
Thank you so much, Meredith, for your insight there. And yes, our next speaker is Pamela Schwartz, the Senior Director for Community Health Impact and Learning with Kaiser Permanente. Pamela, again, thank you for joining us. We are excited to have you here.
Great. Thank you so much. And I want to thank Meredith for setting the stage on really painting the picture of what social determinants of health looks like. And I'm going to take kind of a higher level approach, showing you a variety of social determinants of health type initiatives that Kaiser Permanente is doing. So first, let me just say a little bit about who we are, that we're the nation's largest integrated health system, and we touch the lives of millions of people. So we have a little over 12 million members, and also those members live in communities that have nearly 70 million people. So 70 million people living in our footprint. And we're not just about delivering high quality health care. Our understanding of health has been evolving over the past several years, and we've learned that we can't limit our view of health just to healthcare, that health goes beyond healthcare, and that healthy individuals need healthy communities, and also healthy communities need healthy people. So there's no way to improve the health of our members unless we're optimizing the health of their communities. And so in order to improve health outcomes across our communities, the evidence has pointed to invest in social health. So we've been creating social health by the way we serve our members and also the way we work with our communities. And I'm going to talk about both today. So both how we serve our members and how we serve the broader community. To start, we've been really trying to get to know the needs of our members. And here's what we're learning. We're learning that many segments of our own membership have pressing social needs. And so we've been trying to look at what those are. And on the screen here, you see the top social needs across our membership. So we see we've got food insecurity, housing, which was already talked about quite a bit by both speakers before me, and then also transportation needs, which is also mentioned. And in addition, in June of this year, we surveyed Americans, so going beyond our membership to the broader United States, to see what kind of unmet social needs the broader population was reporting. And it looked similar to this, and what we saw was that many people have unmet social needs and that those needs posed a barrier to health. We saw that 80% of Americans said that it would be helpful for their medical providers to share information, recommend resources, and also help them apply and follow up on services, and that medical providers should ask about social needs during the care visits. So again, I'm going to give you a flavor of a few of our initiatives that are targeting social determinants of health. In May, we announced the launch of Thrive Local, and Thrive Local was intended to address the unmet social needs across our footprint. So Thrive Local integrates clinical and social care, and it's supported by data integration and also partnerships with community. It consists of 3 components. There's a resource directory that provides current, up-to-date, and searchable information on community resources. It also has a geographically based network of social service organizations in that particular community, and then a technology platform that allows for 2-way referrals between the healthcare providers and the social service providers. And we're just getting started with this, and the intention is to build it out across our footprint.